There. Is my screen visible? Is my slideshow visible?
Yes, it is. It is
So I will
visible.
carry on. So it is now superfluous to mention that we know what development basically is. It is a process of maturation of function and acquisition of skills for optimal functioning of an individual. It basically reflects the neuronal maturation, which includes neurogenesis, synaptogenesis, myelination, and prior to delivery, before birth, it proceeds in a cordocephalic fashion, and after delivery, it proceeds in a cephalocordic manner. Certain primitive reflexes are lost before milestones are attained. This just shows how the neuronal complexity increases and keeps on increasing by till 2 or 3 years of age, and that is where the most of the insults or stimulations affect the brain of the child, and that's how our developmental outcome is assured. After 4 years, those synapses or networks which are not used undergo synaptic pruning. Now, development is not basically physical; it is basically our ability or how to achieve the full potential of physiological, emotional, intellectual, as well as how to become the full potential of productive and creative potential. It is very important to detect and intervene early, and a holistic outlook of nurturing early childhood developmental care is what is advocated now. Now, what is the prevalence of global developmental delay? There's a study which says 1 to 3% of all, it's a prevalent in 1 to 3% of all population. The WHO says that 15% of the world's children, of the world's population, lives with some sort of difficulty. The American Academy of Pediatrics says that 15% of 0 to 17-year-olds have some sort of disability. There are cognitive delays, speech and language delays, learning delays, and of course, motor delays are also part of the delay spectrum. Coming to India, the INCLIN study is the most widely quoted study from India, and which studied around 4,000 children, and it estimated that 12% of 2 to 9-year-olds in India had any sort of delay, and out of which 23% had more than one type of neurodevelopmental delay. This is just a repetition of the same. If you look at the CDC statistics for autism, which is also a type of neuromental, it is clubbed as a neurodevelopmental disorder, there has been mounting increase in numbers. In 2000, the incidence was 1 in 250. And in 2020, it is 1 in 54. That's how common autism is becoming. And there are many reasons for that, which we will go into later. In India too, autism is very prevalent. Is highly prevalent. If we consider 2 to 9-year-olds, almost 2.4% is the prevalence. If we look at the prevalence in a developmental clinic, which is where most of the developmental children, delay cases are referred, they show, that is MKC Nair's study in Trivandrum, he showed that nearly 50% of those had no cause actually for their delay. No cause could be ascertained actually. And this is slightly detailed version of it. It says that nearly 50% the delay, no cause was found, and all children who were referred did not actually have delay. Around 60% were actually normal children. And speech and language delay was also very common, and also neurological conditions like cerebral palsy, mental retardation, and attention deficit. This was their study. The causes can be grouped into basically 5 headings, whether they be prenatal, natal, or postnatal. Biologic factors, which are actually insults to a supposedly normal brain. These insults are very common in the neonatal age group and in the first 1 or 2 years of life. For example, we are all familiar with the NICU graduates who were born low birth weight, who had some sort of a birth asphyxia, hemorrhage, hypoglycemia, hyperbilirubinemia, prematurity. But the start is the infection because it complicates all other types of insults. Other factors, which may be genetic and metabolic factors, they are inborn and we can't do anything about it, but we can detect it early, intervene, and prevent such things from happening if we can find an etiological cause or a genetic cause. Nutritional causes are important: iron deficiency, vitamin B12 deficiency, vitamin D deficiency, and of course, protein calorie malnutrition also play a part. But very important is the emotional, environment, and psychosocial factors. And in a large number of cases, the factors are unknown. This is just a repetition of the causes which can happen. I'm skipping through this. This all has been mentioned before. And of course, I have underlined poor nurturing care because this is something which underlines many of the of our children's status. Absence of a nurturing care is a lot of it is linked to poverty, and that is the most common environmenting factor. And even in these cases, breastfeeding and maternal education have been shown to be protective factors. These are the 5 domains of nurturing care which good health indices in the country can help us to attain. The new age issues which plague, because these sort of developmental delay can also present with speech delay and scholastic failure and behavior disorders. These type of nuclear family issues and the lack of support of the extended family of grandparents, aunts, uncles, and extended family members. Now, what is development and in which domains do we assess development? Grossly, we know that the motor domains, which include the gross motor and fine motor domains, the personal, social, and adaptive domains, which is the social developmental domain, the language domain, and interlinked with these is the vision and hearing. But these, the above ones which I have mentioned, they are very well, they can be elicited if we put in the developmental screens like the Denver development or Trivandrum development, and listed the language evaluation screen from Trivandrum, which is particularly useful for language assessment. However, these lack other problem solving and cognitive and adaptive skills assessment. And these are better done by formal development assessment like the DASI, which is based on the Bailey scale, and the Ages and Stages questionnaire, the 3rd edition, which has been validated in many studies from India and seems to be a promising tool, which will also help us to assess the psychometric problems or the cognitive skills and adaptive skills of the child. Dr. Harshita had recently, in the recent past, elucidated the milestones, normal developmental milestones in great detail and beautifully. We will not go into detail here. I will just flag some red flag signs which show that these are the ages by which certain milestones have to be attained and beyond which it is definitely a delay. But we must remember that loss of comprehension or loss of skill or loss of speech or other skills at any age is definitely a very important red flag sign. If we go for autism, because it is so common now, the autistic spectrum disorder, we have to remember a couple of things. If a child doesn't respond to a name by 12 months, doesn't babble or coo by the same age, doesn't point to objects, or doesn't wave by 14 to 16 months, doesn't say single words, or doesn't have any pretend play by 18 months, or doesn't say 2 words to link her name, to link 2 words by 24 months, then these are warning signs of autism. We must be following these children, maintain surveillance of these children by doing certain basic screens and following up so that we can see how they are progressing, whether they grow out of it, whether it's just a temporary delay or these delays persist and they are accompanied by other social communication delays. It is very important to incorporate development screening and surveillance in the well baby clinic, because this is the time the child is not seriously ill and doesn't need immediate attention of any other kind. So screening is basically use of validated tools to identify children who have a high risk of delay. And it is basically a snapshot in time. But when we monitor these children for over a time to see how they progress, then that is called surveillance. Routine screening is very important But in our country, it is not prevalent. Structured screening is not prevalent due to many causes. Sometimes it is due to parental awareness, or whether because the acute illness is prioritized. Doctors also don't feel confident to use the tools or aware of which tools to use. And many a time there is lack of definite guideline as to what tools would be relevant in our country. Although the government has defined developmental delay as one of the 4 Ds in Rashtriya Bal Swasthya Karyakram, which is the RBSK for 0 to 18 years, however, the implementation could be better. Now, these are some of the screening tools of international origin, which we often use or we know about, we hear about. These are the tools like the Denver Developmental Screening Test, the Bailey Infant Neurodevelopmental Screen, which is the BINS. This is different from the Bailey's formal assessment, and the Ages and Stages questionnaire that we were talking about. Some of the Indian tools which are used are the Trivandrum Development Screening Chart, the Baroda Developmental Screening Chart, and the ICMR Psychosocial Developmental Screening Test. This chart tells us which is the age group to use, how many items are there, approximately how long it takes, and what is the specificity and sensitivity of these tests. As I have said, although we know of all these tests, we don't have a clear-cut guidance as to which would be the best suited for our country, because many of them are actually made for Western children and have to be adapted. The questions have to be adapted culturally for our own setup or our type of population. ASQ, which is the Ages and Stages Questionnaire, has been validated in several studies, especially Dr. Monica Juneja in, I think she's in Lady Hardin Medical College. She has used ASQ, and it has the potential to be used in India after its translation into local languages. However, it is originally parent administered, but in our case, if the parent is unable to complete it, then interviewer administration can replace parent administered questionnaire. This is a picture of the Trivandrum developmental screening chart. It can be used from 0 to 6. Two charts are present. One is from 0 to 3 years, and the other is 3 to 6 years. And basically, they are bars. The left-hand bar shows the earliest age by which a particular skill is attained, and the right-hand end of the bar tells us latest by which the skill should be attained. And if it doesn't attained by the latest age, then there is a delay. The specificity and sensitivity depends on how many, we don't get a developmental quotient, but we know that there is a delay in that field. And many studies have used at least 2 delays to increase the specificity of the delay diagnosis. Now, once we screen, once we know that the child may need more attention, more detailed elucidation of the child's problems in a developmental clinic. So who should attend a developmental clinic? All NICU graduates who have a high risk on risk stratification should be referred to a developmental clinic. Any child in the newborn age or around the newborn age who has multiple congenital anomalies, maybe a floppy child, has feeding and swallowing difficulties, or who has been shown to have a delay during surveillance, or any child whose mother, teacher, or doctor is concerned needs to be referred to a developmental clinic. This is a too busy slide. It is just to show the grading, Levine grading 1, 2, 3, and it tells us that the younger the child, the younger the gestational age, the lower the weight, and the more the complications like meningitis, kernicterus, lung disease, ventilation, IVH, these are all increase the risk stratification for the child, and these children should be referred. This is just a repetition of the same thing. However, later on, when the initial 1 or 2 months have been insignificant or nothing major has noticed, later on, the parents may see that the child is failing to interact or smile at the mother, or even later on when the motor developmental takes place, if it doesn't takes place on time, then motor delay can be the presenting feature. And later on, when the child learns to speak and the child doesn't speak at the time when it should be speaking, when it should be doing so, then they present with language delay or difficulty. And when there is difficulty or delay in all fields, then they can present at any age. Later on in the school age, difficulties with again language or behavior issues or scholastic issues may come up. So the issues which come up depend on the age of presentation. This is a slide which shows what the high-risk clinic in the CDC Kerala, how it approaches the children who have been referred from the high-risk NICU stratification. They basically do a medical examination, but whereas neurodevelopmental assessment is concerned, they do the tone and the angle, like the popliteal angle, the adductor angle, which are called the Hamilton angles. And the development assessment is naturally done by Trivandrum Development because they do it at CDC. Hearing is done for all children, and a retinopathy of prematurity is checked at the proper age that it should be. There is a different age when it should be done. One cannot do it randomly, and that age for assessment for ROP is it is given as it should be done. For example, if a child has been born at 30 weeks, then the assessment should be done after 4 weeks of birth, that is at 34 weeks. If the child has been born at 25 weeks of gestational age, then the assessment should be done after 6 weeks, which is around, say, 31 weeks. Like that, there are definite guidelines. This is just to show the angles. These are the angles which are normal angles, and if the angles are less, that means the tone is more. Other than the newborn age group, what will help us is basically we use evidence-based practice guidelines as suggested by guidelines from the American Academy of Pediatrics, the American Academy of Neurology, and the TIDE protocol. So this is for those who come beyond the neonatal age group or those who are not the high-risk NICU graduates. So this is a very important slide. It shows that the history and the physical examination is the most important bit of information, provides us the most important information which will guide us as to what further tests we will do. Most of the guiding evidence, or most often we can get an idea about what is probably wrong with the child by a good history and a thorough physical examination. All children should ideally have an audiology check and as well as an ophthalmology or optometric check. If we suspect a seizure, or if we suspect that seizure could be the cause of the delay, then EEG can be recommended. At the end of all this, if we suspect a diagnosis, then we go for confirmatory testing. If we suspect a genetic disorder, then accordingly we go for that test. For example, if we suspect Down syndrome, we do a karyotype. If we suspect Noonan syndrome, then we do a relevant genetic test. If we suspect a Prader-Willi or Angelman, we do the methylation test. Or if we suspect that there's a large head or a small head or a neurodeficit, then we may go for imaging. However, if we are not at the end of a good history, physical examination, basic examination, we also do a developmental, current developmental level also. At the end of this, if we are not sure of a diagnosis, we still have no clue as what could be the cause of it. Then what they suggest is the first line test to be done is the chromosomal microarray and Fragile X testing. Tier 1 investigations, which are basically blood investigations, they are done for when we suspect inborn error of metabolism. We will go as to when we suspect inborn error of metabolism, we will see in the current slides. If we suspect there is an abnormal neurological exam, there are seizures or macrocephaly, then brain MRI will be very informative. And if we suspect that the child could be having regression and stereotypic movements of the hands, we are thinking of Rett's, we consider MECP gene detection. If by this we come to a diagnosis, then we can counsel the family, give antenatal counseling and referral as needed. Still, if we don't, then there are the other conditions, then there are the other investigations we can think of as the tier 2 of TIDE protocol. which we are coming to in subsequent slides. Finally, after all these tiers, if our diagnosis is established, then again we go for counseling and a referral as needed. And at the end of everything, we still don't have a diagnosis. We periodically evaluate and keep on our surveillance. And ultimately, we may come to a diagnosis, but in a large number, we still may not come to a diagnosis. This is a busy slide which shows that what all should we ask in the history. We should ask for all the relevant perinatal history, the birth history, and especially the family history, a three-generation review looking for miscarriages, birth defects, deaths, delays, neurological conditions, and definitely if there's a history of consanguinity. Psychosocial history is equally important, as we have been emphasizing from the beginning of this talk. A good physical examination, which includes anthropometry and head circumference, its shape, any cutaneous stigmata, spinal abnormalities, cardiac or organomegaly or cardiac abnormalities, and limb defects. However, especially for neurodevelopment examination, we should focus on the neurological deficits, any abnormality in tone, power, jerks. What about the plantars? Presence of primitive reflexes, any abnormal movements, and gait, ataxia, or otherwise. Congenital anomalies, dysmorphic features, a clinical genetist or dysmorphologist can be a big help in the rare diseases, in the rare causes. And of course, we do a current developmental level for follow-up. As I have just mentioned, we can either go for a particular targeted test when we suspect an etiology and we don't, and when we can't, then we go for the tier 1 and tier 2 tests. This is just a slide which shows what test is important where. When we do a sequencing, then we can look at even one base pair, the single nucleotide polymorphisms. When we do a microarray, chromosomal microarray, we can detect any abnormality in more than 15 kilobase pairs. And that is looking at the copy number variants. And FISH detects abnormality, which has more than 1 megabase pairs. And karyotype detects abnormalities when we are looking at abnormalities bigger than 3 megabase pairs. And each is relevant in its own, each is important in its own type of investigation or type of disorder that we are trying to find out or elucidate. This is just a slide depicting clinical microarray or chromosomal microarray. I won't go into a variant of unknown origins. And when we are looking at the chromosomal microarray, many a time we will be able to find out the cause, but many a time we are left off variants of unknown significance, and where we don't know whether this variant of unknown significance is actually causing the disease or it is just there and it is just associated but not causing the problem, not the causative problem. In that case, in such cases, we have to go and look at the parents. If the parents are normal and they have a normal chromosomal microarray, then probably that variant is pathogenic and it is de novo in the child and is the cause of the disorder in the child, of the delay in the child. However, if the parent's chromosomal microarray done shows that one parent has the same result as the child, and the child and in this case the parent is normal, then this variant is not pathogenic in the child. However, we must keep in mind that other predisposing factors may be the responsible, or maybe that the parent has the variant which is pathogenic, but it is in reduced penetration in the parent and the parent is not actually very symptomatic. So these are all in the realm of genetist, and I think in here we have to take the help of a genetic specialist to elucidate or to further unravel the problems. When we have these variant of unknown significance, we have to use database, which we can't do. I don't think we are equipped to do it, and we should refer them to a genetist who will be able to guide us through the databases. When do we suspect that there could be an inborn error of metabolism which is responsible for the delay? This is a busy slide, but I have tried to just shorten it and talk about the important guiding factors. So these are guided by the physical examination, good history, and of course the systemic examination. If there is developmental regression, if there is a history of early childhood deaths in the family or in earlier siblings, if there is a previously diagnosed metabolic disease in any family member, if the child has hypotonia or hypertonia and generalized weakness, if there is visual and or hearing impairment like a cataract or other such, and if there are dysmorphic features with organomegaly, then think of a metabolic cause of the delay, and then metabolic tests are indicated. This is again a busy slide, which is the American Academy of Pediatrics recommended tests to be done where we suspect the inborn error of metabolism could be responsible for the developmental delay. But in short, we must be doing the blood gas and the blood lactate, glucose, homocysteine, ammonia, blood for tandem mass spectroscopy, urine for GCMS, and other tests depending on clinical suspicion. So basically, this is an expanded list of the same with more inputs. Lead level and iron deficiency and vitamin B12 deficiency could be important in our setting when there is nutritional deficiency. As I said, EEG is when we suspect seizures, because many a time EEG may be abnormal without actually causing the delay. MRI, we have talked about. MRI, in absence of indication, contributes to only 0.2 to 2% in elucidating the etiology. However, when it is done in case of certain indications, then the yield is much more. So if there is atypical regression, there is microcephaly, macrocephaly, abnormal neurological assessment, seizures, and intracranial manifestation of syndromes, then MRI has a good yield. So with this knowledge, we will come to a few cases that we have seen. I must say that ours is not a very detailed neurodevelopmental clinic. Often we are unable to do the tests we would like to because of the cost and because of availability. And of course, the COVID situation in the last 6 months has been a handicap. However, this is case one. Sara Khatun is a 1-year-old female born of a third degree consanguineous marriage, has severe delay in all domains of development, especially having feeding and swallowing problems, so much so that she was born at 2.1 kg and her current weight at 1 year of age is only 4.5 kg. So that shows how severe the feeding and swallowing difficulty was. She has a very small head, 31 centimeters, dysmorphic, however, no neurocutaneous markers. There was hypotonia and drooling with poor head control, but the planters were brisk and up, but the jerks were brisk and the planters upgoing. She had come with a Bera report, which was normal. Vision, we hadn't checked as yet, but the MRI showed us what it was. This is the child. And it is not rocket science to guess that this child may be having some sort of cerebral dysgenesis. So instead of going for any of the genetic tests, we went for MRI, which showed that this child had pachygyria. Another case, 9-month-old Pranav Shah. As you will see that most of the cases, we don't have to go to detailed tests and we don't have to go to tier 1, tier 2 tests because history and good clinical examination gives us a clue straight away, and then we can have a diagnosis by doing the targeted test. So Pranav Shah came at 9 months, who's having gross developmental delay, and he was not looking at his mother, not fixing and following. He was a second twin. He had a other healthy twin sister of his own age. He was born in a government college, and on day 2, government medical college, and on day 2 of life, he was detected with neonatal sepsis due to Klebsiella. I must say that the discharge certificate of the government hospital was very much in detail, and it helped us with a lot of history because our parents are unable to actually give a proper history on their own because of because of their inability to understand a lot of the things that have happened. The child also had seizures, and the child had hypoglycemic episodes during an ICU stay. When I saw that the child had a gross developmental delay, whereas his sister was sitting and eagerly looking at this bottle, this index patient couldn't even lift his head at 9 months. And as you can see, his mother is holding him, and still he cannot sit without support at 9 months. Whereas his sister is all happy. She's having a lot of stranger anxiety because she has been brought to the OPD along with her brother, and she's now trying to fiddle with the object. So directly, because the head size was small and he was an eco graduate and had seizures and hypoglycemia, and of course was not able to see. From what we gathered from the clinical examination, we thought of insult to the brain. So the MRI was advised before anything else, and this showed that this child had parieto-occipital hyperintensities. This could be due to hypoxic ischemic insult or the hypoglycemic episodes that the child suffered from in the neonatal age. And that is what it says. It says hypoxic. This child was intervened actually. There was a physiotherapist who was involved with the action of the child. He was also doing a bit of occupation therapy by sitting him and making him sitting in certain postures for certain prolonged periods of time. And 4 months down the line, 3 months down the line, actually, when the child came, he was definitely somewhat better than what he was in the last visit. This is another case of a 4-year-old child, Nayan Adhikari. He came with speech delay. There was no particular significant history in the family, and there was no family history of delay or family history of hearing deficit. Everything else was normal, but he didn't respond well to commands. This is the child, he's so bright and he's so responsive, good eye contact and playful. He looks very intelligent also. So we did a hearing test for him. And this hearing test showed that there was abnormal study in 1 year. So we need to understand that even though the child can hear, but the child cannot hear fully well because 1 year is not working well. And that also can cause speech delay. Shatoki is another 3.3.5-year-old male who had again speech delay. And his speech was also unclear. Father and uncle were late speakers, but otherwise no other significant history was there in his own history or family history. The child was otherwise fine. There was no neurological deficit, neither any dysmorphic features, no neurocutaneous markers. But the child had unclear speech. And of course, there was a history of familial delay. We did a test which showed there was only language delay, others being okay. And ISA showed that there was low risk for autism. So the child was actually didn't have a communication or social communication disorder. Again, there was an intervention by a speech therapist. He was given age-appropriate toys, and the parents were showed the play therapy. And 6 months down the line, the parents were very happy with the progress because he had progressed a lot. So I wouldn't like to go the whole hog, but we can see that the child is somewhat distracted, but does make good eye contact. And when he is sufficiently engaged, he follows commands, points, and starts talking. But again, his articulation is not very clear. So he had problems of articulation of speech. He didn't have a problem of language, but he had a problem of speech articulation. Very interactive. So this is another case that we are coming to. This is a case of Dr. Veronica Sharma from Gangaram Hospital. And this is a child who had come with global developmental delay, with intellectual deficit and autistic features. He also had scoliosis and pes cavus. And of course, we can see the telltale signs of a long face with prominent forehead, large ears, and a prominent jaw. And this child had Fragile X syndrome. Fragile X is a very common cause of intellectual disability. And the test to diagnose it is the DNA methylation test, which shows the FMR gene and a breakage in the FMR gene site. So what is important to remember is that in children with intellectual deficits, even if the no telltale signs are there in the face or in the other domains, it is one of the most common genetic causes, representing 2 to 6% of affected boys and 1 to 4% of affected girls. And because the clinical phenotype is often non-specific in infants and children, in young children with Fragile X, the guidelines say that Fragile X testing or FMR1 gene testing should be considered as part of the first-line investigation of boys and girls with generalized or global developmental delay or intellectual delay as defined in DSM-5. This is another of Veronica's cases, and this is a 5-year-old girl who came with the global developmental delay, autistic traits. She was hypertonic and she had disorders of posture and balance. However, she had a very happy demeanor, and the child, as suspected, turned out to be genetic, the deletion in the chromosome 15q11, the maternal deletion, and this is the Angelman syndrome. This is a child who came to our clinic. The child was actually diagnosed outside and she had come for confirmation, and somehow probably she thought that our clinic would, coming to our clinic would make the diagnosis more certain. The child was 7-year-old Nabishta Sultana, born premature, initially had feeding difficulty and had a very slow weight gain, was floppy and had delayed milestones. But later on, the feedings improved. Now she's a voracious feeder, she's overweight, still the gait is unsteady and has poor scholastic skills. And these are the features of Prader-Willi syndrome, and the targeted sequencing, which was done already outside, showed that she had a deletion in the chromosome 15q11 to q13 region. And this is due to deletion of the paternal part of the chromosome. This is another type of child which we see very often now. So actually, I am very worried because I am seeing a fraction of the children, but still this is so common in our OPD. And this child had come with language delay, but you will be able to clearly see that he had delays in communication, resounding delay in communication. Whatever the parents are saying, he doesn't seem to be bothered. He's only lost in his own world. He has noticed something, and that is the focus of his attention. And he can actually filter out all other inputs or calls from the mother or father or anyone else. He's also a bit hyperactive. Hyperactivity is very often associated with autistic spectrum disorder. So not interested anyway, he doesn't point, he doesn't speak, he doesn't have echolalia, but he doesn't play with peers, he doesn't have pretend play, and he doesn't respond to any calls or follow. So if you consider DSM-5, he has all three of the A category of criteria. He has a social communication deficit, he doesn't make eye contact, doesn't have any joint attention or pretend play, there is poor non-verbal communication, and there is failure to initiate and maintain relationship, that is to interact and play with children of his own age or even other ages. He has motor stereotypies, he flaps when he's excited, and he's very fixed with routine. He doesn't like certain colors, and he resists change in those things. And he's also had food fussiness. He's hypersensitive to the sound of pressure cooker, so there are B symptoms. So he has at least 3 of the B symptoms and all 3 of the A symptoms. And these have been present from a very early age, and there's no other explanation. And these satisfy the DSM-5 criteria of autistic spectrum disorder. MCHAT was done, but basically observing the child and having an impression about the deficits of the child by a trained physician who has an experience is the most important diagnostic. I would say that would satisfy the diagnosis. When MCHAT is used as a screening test and is used it is recommended by the American Academy of Pediatrics that all children should undergo the MCHAT screen at 18 months and 30 months to screen out any early features of autistic traits. Now, we must remember that neuroregression can often present as a delay in development, as this child did. They complained that she wasn't able to hold her head nor able to sit, and this is a 3-month-old. This is a actually 5-month-old child. So there is no rocket science to mention that there is fibrillation in this tongue and this child is suffering from spinal muscular atrophy. So at the end of the talk, the key message that I would like to convey, and I would like the postgraduate students to imbibe, is that structured developmental screening should be done in all children with certain tools, and one must have certain basic training to be able to do this and to know which tool to use, because perfunctionary or just asking a few questions doesn't show that it can pick up all cases of delay or all domains of deficit. NICU graduates should definitely be referred to a high risk clinic if they can be stratified as a high risk strata by the Levin grade 2. Any NICU without a high risk follow-up is like doing a cochlear implant without speech therapy. So any NICU should have a high risk follow-up clinic. A thorough history and clinical examination is most helpful in guiding us to suspect a cause for the delay. If there is a cause suspected, we must go for targeted tests, and there is no need to follow a whole protocol of tests. However, where there is no apparent cause evident, even after a good history and clinical examination, then the chromosomal microarray and Fragile X gene detection would be the first tier tests. MRI should be done when there are certain features like a large head or a small head, a neurological localization, or seizures. Metabolic screen should be done in certain conditions, especially if there is consanguinity, if there's a family history of metabolic disorder, if there is an unexplained death in the sibling or family members, organomegaly, dysmorphic features, seizures, or regression. We must remember that metabolic screen would be in order in these cases. EEG should be done when seizures are present or suspected to be the cause of the delay, and random EEG in all cases is not necessary. Thank you. So I would be happy to answer any questions. I wonder if the PGTs, if the students have any questions. They seem to be very satisfied all the time.
Child who had that parieto-occipital involvement, I mean, with neonatal hypoxia, probably HI sequelae and or hypoglycemia. How was the vision in the child?
The child was totally blind. The child was not seeing and following at all. We have referred to the child.
Blindness indicate.
But there was perception of light from the outdoor clinical, whatever assessment I could do. The child was squinting at light, but the child was not following at all.
Okay.
So basically that was evidence of cortical blindness. The child has been referred to the ophthalmologist. The child hasn't come back. But I think the cause is there in the parieto-occipital hyperintensity.
Cortex itself. Yeah.
খুবই ভালো presentation হয়েছে, but my only suggestion is that for your future, never keep your presentation long for more than 30 minutes.
Yes.
Because I have repeatedly told everybody that prolonging for 30 minutes, more than that, unless and until each and every different cases, like the last part that you have shown are different cases that you have shown, that attracts the attention of the public. But when it is a first part was too theoretical, and second part was actually more practical, which attracts, but by then I'm seeing one after another person is leaving. So give the best of your presentations in the beginning. যে cases গুলো আমি আগে দেখাবো, দেখিয়ে, and each on the basis of each case you should get how should I go about this case, how should I go about this case, এরকম.
Yes.
But otherwise কি হয়েছে যে first half an hour plus you showed only on theoretical aspects, and always remember that many are actually seeing in the mobile, and so they cannot see actually the whole the slides. But if it is a video or if it is a clinical presentations of a picture, they can see. So this is regarding the presentations that you will be doing. Never ever keep your presentations for more than 1 hour, unless and until you are giving a oration where you are showing different cases where you may extend. But those are different cases, not only on one topic. That's my suggestion is.
True, yes. I also realized that my presentation is very long, but then by that time it was
but you should always give a trial. Means my experience, I've seen some cases developmental delay, nothing could be found, everything is normal, but turned out to be a creatinine synthesis disorder.
Yes.
So so these are the new inputs you should give. Regarding Prader-Willi case that you have shown, I think the best test for Prader-Willi is the methylation test.
Methylation test,
DNA methylation test.
It detects the imprinting problems.
We don't go for genetic tests straight away, but we go for the DNA methylation test. But if it is very simple, you can try for a fish study, which will be positive in 70% of the cases. And so to make it more simple and less costly, I usually go for, if I have a strong evidences of the clinical features of Prader-Willi, I go for fish study. And if fish study is positive, then I know, okay, we are on the right track. But if you want to see that whether there is a uniparental disomy or not, then you need to go for other tests also. So there are some subtle cases যেখানে metabolic defect like creatinine synthesis disorders or MECP2 genes, so ওগুলো কিছু কিছু আসবে। তো ওরকম কেস ওরিয়েন্টেড বললে মানে because this topic itself is very boring. I remember in 2013 in national conference I talked on a developmental delay, when to suspect and what to do. So it's very boring, but case based করলে সবসময় ভালো রেজাল্ট পাওয়া যাবে।
Thank you, sir.